Right. So my brief in this particular section is simply to talk about the Irish experience of newborn screening, which I guess in some ways, apart from very, very developed and forward-thinking countries, is probably the usual experience. But we'll talk about it. So hopefully we can get this to move on. Oh, sorry, just bear with me because I'm not showing this correctly. Apologies there. Yeah, okay. So I think the first thing, and it's already been brought up, and it's been brought up by Laura and that lady from Belgium, who was white, but has a sickle gene. So, I mean, the first thing that we need to know is that sickle genes, it's not just an African issue. Yes, predominantly the sickle gene arose about maybe 6-7 times spontaneously in Africa, but it also arose in the Arabian Peninsula, and probably it's the Arabian gene that went over into India with various migrations. And of course, then with the migrations, forced or otherwise, of the African populations going back over generations, the sickle gene has moved. And it has moved from the 13th, 14th century into Europe. And so absolutely, you are going to find the sickle gene in apparently white populations. So this is not an African issue. I think that's really important. This is a European issue. And the second thing really is just, you all know this anyway, so I'll just put it up, that what we're talking about is the inheritance of, we should have two genes that are a series of genes that govern the production of a hemoglobin called hemoglobin A, which is the normal hemoglobin and does normal things. But the sickle, if you like, hemoglobin is made because there is a genetic mistake going back over thousands of years, in fact. And sickle hemoglobin had advantages because it did help protect against malaria when there was no other protection against malaria. But we wouldn't recommend it now necessarily as being the only thing. So please take your malaria prophylaxis. But basically, it's a genetic disease. So it's no one's fault. It's a genetic disease. And what tends to happen is that two apparently extremely well people, because they're carriers of the gene, they don't have the disease, they're carriers of the gene, but they get together, and if they get together, there's a 1 in 4 chance with every single one of their pregnancies that they will have a baby with sickle cell. And so that means they could have 10 children in the family and all 10 could be affected, or they could have 10 children in the family and maybe only one's affected. Or they could have 10 children in the family and nobody's affected, but they will pass on the gene. So we will still have carrier state within that family. So I think it's important. And as I say, it's just in a way you could argue it's fate. So the effect of sickle cell disease, just in its simplistic form. Well, there's a picture of a sickle cell disease, or a sickle cell. Okay, and you can see it's a funny old shape. And the schematic is to demonstrate one of the phenomena associated with particularly hemoglobin SS, which is that it blocks blood vessels. And we call it blocked blood vessel vasodilation. This is one of the causes of sickle cell crisis. Now, you can have a crisis or you can have a silent crisis, but either way, you're causing damage. We get anemia because the sickle cell, the funny old shape there, doesn't last as long in the circulation as the nice round ones that you see. So we get anemia. But from a newborn screening point of view, actually, one of the big issues is that it increases the risk of infection, because really from pretty much the time the baby's born, and we certainly know from about 6 weeks after the baby's born, we are starting to see poor spleen function. And spleen is important to fight infection. And fighting infection is very important when it comes to bacteria. Okay, so therefore, children with sickle cell disease, young children, before they were ever diagnosed, oftentimes have died of sickle cell. And there are reports of children as young as 8 to 10 weeks dying of infection, and they've had sickle cell. So this is actually one of the fundamentals of why newborn screening is so important. Okay. Right, so this is an old, and I do apologize, this is an old slide, but it's just, again, to demonstrate that, you know, when people say, oh, well, sickle cell disease, that's really nasty. So what can we do about it anyway? Well, of course, there's lots of things we can do. You can see there, and actually these mirror hemophilia trends as well in many respects. You can see that when these figures from the National Institutes of Health in Bethesda were started to be put together, you can see that for the first maybe 60 years of figures, really life expectancy was terrible. And then people start to take notice of sickle cell disease. And people start to take notice of sickle cell disease specifically because there was a groundswell to the Congress in the States saying, don't forget about sickle cell disease anymore. And so there was a National Sickle Cell Act, which allowed for newborn screening, allowed for treatment, and you see that this was really important. And then preventative penicillin added in, we'll come back to that again. And that made a real difference. And then we have the other things that we can do for sickle cell. But you can see that upward trend started because of that Sickle Cell Act, because of peer pressure to congressmen and women, but mainly congressmen at that point. So, okay, so why bother with an early diagnosis anyway? Like, does it really matter? Sure, you're going to get picked up when you have a crisis. So, like, doesn't matter? Well, first thing I've just said, that children were dying of infection before they were ever diagnosed, and that's still happening in Africa. So without newborn screening, only 61% of patients with sickle cell disease were diagnosed in the first year of life. We published a paper in 2015, having looked at our data over the preceding 12 years, and it was our figures mirrored this precisely. 70% of our patients were diagnosed when they came in with their first case. There is a proven benefit for early treatment with penicillin and vaccination, okay, pneumococcal vaccination, because if you have poor spleen function, the 3 organisms that would kill you are pneumococcus, or Haemophilus influenza, and meningitis. But the 2, from an early childhood point of view, would be pneumococcus and Haemophilus influenza. And there's been lots of papers, and I just picked one, but in actual fact, in the 1980s, there was actually a series of papers demonstrating that actually if you treated these children early with penicillin, with pneumococcal vaccine, it made a real difference. And so this paper in 2000 said that actually we can avoid 1.25 early deaths for every 100 children diagnosed before the age of 6 months of age. And we've demonstrated that again in our paper that the mortality can reduce from 8% to 1%. So there's I think an overwhelming bunch of evidence to say that this is the case. So this is what I've alluded to already. This was our consensus conference. It was very interesting. It was actually our convener was Stefan, but Kohinga Frempong actually did a wonderful job, because we invited him to help us to actually get a meeting of minds. And so there's, for anybody who hasn't read it, I think please do get it. British Journal of Hematology 2018. But this, and I've spelled prophylaxis wrong, I do apologize for just noting that now. But basically, this was one of the key points, that early diagnosis by newborn screening together with anti-pneumococcal, penicillin, prophylaxis, and vaccination, along with coordinated follow-up parental education, will reduce morbidity and mortality from sickle cell disease in childhood. And getting that basis will bring us forward into better care. I just wanted to point out where Ireland is, because some people say Ireland is not part of the UK, or Ireland, is that Iceland? No, this is Ireland, and you can see that we are really on the peripheries of Europe. So you might argue, how do we ever get a sickle population? Because it's not endemic in Ireland. But actually, we did have an economic boom around about 2000, and that's actually how this all started. Pretty much the same actually as in Germany. And so we do have a significant population of people with hemoglobinopathy now in Ireland. These are the census figures for 2016 because we haven't had our census thanks to COVID for 2021. So our population is about 5 million. People of African ethnicity about 1.4%. We have one national comprehensive Centre for Pediatrics, which was set up in 2003, and one adult centre which we facilitated and set up, led by my colleague Dr. Emma Toohey in 2015. We're affiliated to the UK peer review programme, and we have audits from them to make sure that that we can say we're actually doing this properly, and we're a founding member of EuroBloodNet. These are our data. We had an upsurge we started at nothing, as you can see there, and our peaks were around about 2011, 2012 in the children's population, and since then we've seen an adult population growing. So my colleague Dr. Toohey is now getting really quite busy, both because we're transferring patients to her, and so we work one centre on 2 sites, birth to death. Okay. And that's our goal, and so we work very closely together. So newborn screening in Ireland then. Well, newborn screening in Ireland commenced in 1966, embolic diseases. Now, we were one of the first countries in Europe to introduce newborn screening, but we have been woeful in terms of bringing it forward. So now most countries will do about 34 metabolic newborn screens, and we really are still stuck doing very little. But we have what's called, it's a universal screening program for blood spot program for newborn screening for metabolic disease. And there's a central lab in one of our sister hospitals, and there's a whole series of things around it. So that's newborn screening in Ireland. Now, what about hemoglobinopathy? Well, it's a voluntary, it's non-government funded, it's an opt-in targeted. When I say opt-in, it's opt-in from the maternity hospitals. Our maternity hospitals and our pediatricians are great. They absolutely 100% endorse this. So they're quite willing to do our newborn screening. And the deal is they do the newborn screening in association with parental consent. We do the testing, and then in the past, we've been seeing the patients, but I don't think that's a very good model. Oh, sorry, we see the patients with disease, but we were also seeing the patients with traits. And I think perhaps seeing the patients with traits is not the best model. But seeing the patients. So we see the patients, because we're in control of the whole process, we would see our babies who have been diagnosed with sickle cell disease really within the first 4 weeks. And that's what we would do. Not every maternity hospital has signed up, but the maternity hospital with the most population have. Our blood spot, which is what most people are doing in the universal program, we use cord blood. And as I say, and I see the patients. Now, I mean, this is lifted directly from a question that Stefan asked in that consensus. What effect has it had? Well, has it reduced death? Well, pre-screening, we did have death of babies with sickle cell disease, but we only diagnosed them afterwards. So therefore, there was nothing that could have been done to save them because the parents didn't know. Whereas now, we have had no deaths in the under 1 year group because everybody's diagnosed. So in terms of the UK standards, then we see, I mean, there are people who just simply do not want to come see us. And so that's why we don't have 100%. We have 100% diagnosis, but we don't have 100% people coming before 3 months. They will come see us eventually, but they don't necessarily want to come. And our time to commence penicillin prophylaxis. The vaccine started 2 months. It's a national program. The penicillin prophylaxis, we like to get our babies in. So that's me done in terms of the presentation and how things are in Ireland. Our program is a grace and favour, as in we've asked our paediatricians to help us, and they've said yes. And we're trying to firm it up, and we're trying to get it on the newborn screening program, blood spot. It would be much more sensible, but we haven't done it. So we haven't got a national program funded by the government at all, but we actually do have a national program, and it's been ongoing since 2000, and it works. And I have serious questions, but I'm not going to ask those questions just at the moment, because I'm going to leave those for the debate.